Hello again. This is chapter 13 in Radiologic Imaging Sciences and Patient Care. And this chapter is all about safe patient movement and handling techniques. Pretty much this chapter is teaching you how to properly move a patient, because in our line of work, we do assist patients all the time in and out of wheelchairs, from stretchers to the table and from table to the stretcher. You are bending, moving, lifting, repositioning, assisting all the time. And the one thing you want to make sure that you do is use the proper body mechanics so that you do not injure yourself, because that is not the goal of you helping the patient, is by injuring yourself. They start off on page 141 talking about body mechanics. And the reason I reference you want good body mechanics is because if you read in there, they cite that that one of the leading causes of disability for people in healthcare is sprains, strains, and musculoskeletal problems. Leading cause of disability for people in healthcare, estimating over 600,000 employees each year and costing over $50 billion. So you do not want to be one of those statistics. You don't want to hurt your back. You don't want to pull something, strain something. You want to be in tip-top shape so that you can assist patients but not become a patient. Okay? When they talk about proper body mechanics, the purpose of a patient transfer, it says, is to safely move a patient from one place to another. Not only do you want to watch out for the safety of the patient, but for the people that are doing the transfer, so yourself and whoever else might be assisting you. When you apply proper lifting and transfer techniques, then you just become safer operating in your job. And RTs that use proper transfer techniques absolutely reduce their injuries and minimize their low back pain. In almost 30 years in practice, I can tell you that I don't think I've ever injured my back or sprained or strained anything, just because I am very careful about what I do and how I do it, because I do not want to end up being the patient. As far as good body mechanics, they reference to use good posture. Always keep your body's line of balance close to the center of gravity. We'll talk about these things in just a minute. Hold objects close to your body. You don't want to try and lift something by outstretched arms. You tend to pull that in close to your torso when you're trying to lift something heavy. Think about you get a package at the front door and it's a very heavy package. You don't stand 3 feet away and try and pick it up with your arms outstretched. You tend to bend, you bend your knees, you try and lift with your legs, and you pick the package up and you hold it close to yourself. Like I said, bend your knees. Don't twist the trunk of your body. Don't ever twist. It only ever leads to injury when you twist. And you want to always try to push rather than pull. Other aspects of good body mechanics is you want to have a good base of support. You want to be aware of your center of gravity and where it's located, because ideally, if it's over your base of support, it makes you much more stable. You want to use the correct muscles for mobility, and you want to use the muscles to maintain your stability as well. So they're going to talk about mobility and stability muscles, and thankfully we do not have to know very much about muscles, other than here you just same things. You want to lift with your legs, you want to stabilize yourself, and when you're moving something, you want to use the mobility muscles, which are typically in your extremities. As far as your base of support, a wide base of support is essential for you to be stable. Okay, and we're going to look at a picture in the next slide, which is at the bottom of page 141, where it shows 3 different people in their different bases of support. So the base of support is the foundation on which the body rests. All right, and it's the area between your feet, including the plantar surface area, in a standing position. So when we look at these pictures, we can see the woman on the left has a normal base of support. The gentleman in the middle has a wide base of support. And this lady, the ballerina over to the right, has a very narrow base of support. Why? Because we're talking about the feet and the distance between them. So typically when you're just standing there, your feet are about shoulder width apart, and that's a very normal base of support. A wide base of support, like if you're going to pick up something heavy, we tend to automatically spread our legs apart a little bit further to help us maintain stability when we're picking up that object. And if you were going to pick up something heavy, you certainly wouldn't stand on one foot with the other foot not even on the ground, because that is a very narrow base of support, because there's nothing between the legs but air. Okay, so think about if you were trying to knock one of these people over, who would be the easiest one to knock over that would have the narrowest base of support? Would be her. The hardest one to knock over would be him, because his feet are kind of planted far apart, giving him that wide base. The center of gravity in most humans, there is a difference between men and women, but typically it's at the level of what's called S2, or your second sacral segment. So S2 is in your sacrum. You can see here they've got the pelvis, you've got the ilium, the ischium, and the pubic bone that make up one os coxae, or one hip bone. So this thing is the pelvis as a whole. And then you've got the sacrum right in here, and at the bottom of the sacrum we have the coccyx. So at the level of S2 is typically where the center of gravity is on most adults. And as far as what is the center of gravity, it's a hypothetical area where the mass of the body is concentrated and gravity works from that area. Okay, see right here, the center of gravity for most people is at approximately the sacral level, S2. Like I had said in that last picture, typically when your center of gravity is over your base of support, it allows for much easier movement, much more stability. So when you look at this baby, her center of gravity is over her base of support, which she's sitting on the ground with her legs kind of frog-legged out, and her center of gravity is over her base of support. So she's pretty stable in that position. But when she's standing up and her base of support is not over her center of gravity, okay, BOS, base of support, COG, center of gravity, when they're not over, she's more than likely to fall over backwards because she is not very stable in this position. Right? So as far as us and lifting things, we want to have the most stable position that we can. So we always try and keep our base of support over the center of gravity. As far as muscles, like I said, we do not do a whole lot with muscles, but on page 144, they show you the difference between mobility and stability muscles. Most of your extremities are your mobility muscles, and the torso muscles are your stability muscles. Okay, and it says for effective patient transfers and handling, we should use our mobility muscles or our extremity muscles for lifting, and our torso muscles and our postural muscles for support. Right? So again, you want to use the legs, you want to bend with the legs, use your thighs when you lift. You don't really want to use, you don't want to lift with your back, and you want to use the muscles of your torso as well. As far as lifting principles, lifting should be done by bending and straightening your knees so that you're lifting with your legs. The back should be kept straight or in a position of a slightly increased lumbar lordosis. Lumbar lordosis is where your back is arched just a little bit backwards. Okay, so not sway backed, but just slight lordotic arch in it, which we all tend to have anyway. You want to allow ample time and handle the patients gently. And you always want to inform the patient of what you're going to do and how you intend to proceed, so that if possible, they will assist you and do most of the work themselves. As far as our lifting principles, you want, when you're going to do a transfer, let the patient do as much of the work as possible. It's much easier on you. And remember, you're going to be doing this every day in your career. Patients come and go, unfortunately. So them doing as much work as they can just saves you in the long run. the less you have to move or the less you're moving when they're quite capable, it just means less risk of injury for you. When you're going to execute a transfer, you want to make sure that the patient is able to do that. You want to make sure that they do not have what's called a weight restricted bearing status. You want to make sure it doesn't say that they don't want to have weight on the legs or they're not allowed to bear weight at 100% just yet. You want to make sure that they're capable of performing what you need them to do and that there's no doctor's order against that. Patients that have cognitive impairments, like if you have a patient with dementia, they can overestimate their ability and they might require assistance. But I would tell you, don't just assume that a patient can't do something. Allow them to attempt to try and see if they can. And if they can, that's great. But if they can't, then you're there to assist them. All right, so don't let patients overestimate what they can do, because sometimes they will do that unknowingly. They're not trying to trick you. They just think that they can do it when in reality they can't. Right? You want to make the transfer slow enough where the patient feels secure, especially elderly patients. They tend to have an extreme fear of falling. So you want to make sure that you move slow so that they feel safe. Patient's center of gravity should be close to the mover's center of gravity. You don't want to try and assist a patient, again, with outstretched arms standing 4 feet away from them. That's not going to do anybody any good. If they have what's called a transfer belt, then those do come in handy and are utilized if the patients have those on. Sometimes they'll have them on the floors, and then we use them as we bring them down. And you want to secure any loose clothing on the patient so that it doesn't get hung up or get stuck as the transfer is taking place. Again, let the patient do as much of the work as they can. Do not twist. When you're lifting a patient, keep your back stationary and let your legs do the lifting. And after the patient is standing, help them to pivot around to their bed or to the x-ray table and to sit down. Okay, so once they're standing, then let them kind of turn their feet slowly and pivot around and then sit. There is something that comes into play when we are moving a patient, and that is called orthostatic hypotension, and that is on page 143. And it's something that we need to be aware of because it is a potential in our patients. What it is, orthostatic hypotension, hypo tends to mean low. Hypotension is a drop in blood pressure caused by a change in a patient's body position. So if they get up too quickly, if they've been laying in bed for a week sick, and then we come in and tell them, okay, we're going to get you up and do this x-ray, and we sit them up and then we try and stand them, they absolutely probably are not going to be able to do that. Again, it's more pronounced in bedridden patients, and the symptoms would include dizziness, fainting, blurred vision, and slurred speech because their blood pressure drops. So make sure if you have a patient and you are going to have to take them from a lying position, let them sit up for a few minutes and kind of get their bearings before you stand them up. Just take everything slow. There is no, you can make up time somewhere else, not in trying to rush your patient, because if you rush your patient and they end up going down for the count, then you've got to fill out an incident report. So you really didn't speed anything up. You actually made your day much longer by how to do that. Okay, so to minimize it, have the patient stand slowly. Encourage them to talk to you during the transfer by asking them simple questions. You doing okay? Everything good? You're not hurting, are you? You're doing okay with doing this? Do you feel dizzy at all? Just something to keep them engaged and speaking to you. And never send a symptomatic patient away and risk having them faint on the way to their room. Always be with the patient back to their room, assist them, even if they say, no, I'm fine, you've got things to do. Nope, not happening. Because remember, you're responsible for that patient from the time you get them until the time you return them to where you got them. Doesn't matter if the patient told you to go ahead, that liability still falls on you. Teamwork, again, that word, but if we are going to transfer a patient, it always requires teamwork. Someone has to take charge of the transfer, and typically that person is at the head of the patient. So in this scenario, this gentleman would be in charge of the transfer. This person would listen to the gentleman and they would work together. She and he would work together to lift this patient, right? They call the transfer play. They control the timing of the transfer, and they synchronize the events. Usually you talk it out with the other person and say, okay, on 3, we're going to lift and move her over. So ready? 1, 2, 3, and then both of you lift. Wheelchair transfers. There are 4 types of wheelchair transfers that we are going to discuss, but the first thing you have to do before you perform a wheelchair transfer is to determine if the patient has a strong side and a weak side. If both sides are equal, that's great. But let's say they have their right side is really strong and their left side is weak because maybe they've had a stroke and that's why they're in there. You always want to move a patient so that you're transferring towards the strong side. So if the right side is the strong side, you always want to move them from left to the right. You don't want to try and move them the opposite way and lead with their weak side, because if they're trying to help you and that's the weakened side, then they have no reasonable way to assist if they start to fall. Always, with a wheelchair and a stretcher, if something has wheels, lock the wheels. Okay? The worst thing you can do is not lock the wheels and have whatever the patient is in start slipping away as they start standing up. So lock the wheelchair locks, move the footrests out of the way so that the patient does not trip over them. And like I said, there are 4 types of wheelchair transfers. There is the standby assist, which really their name tells you exactly what they do. Standby assist, you literally stand by and watch and assist the patient if needed. Assisted standing pivot, you're helping the patient stand up and pivot to get to the table. 2-person lift is what that last picture was. 2 people literally lift the patient. And the hydraulic lift, a lot of times they'll call it a Hoyer lift. That is where you use a device that literally looks and is an engine hoist to lift a patient out of typically a wheelchair or a stretcher and move them to another area. And we'll show examples of all of them. The simplest wheelchair transfer is a standby assist. This is typically used on patients that have the ability to move from the wheelchair to the table on their own. And all you're really doing is providing instructions to the patient continually during the transfer. Like, okay, I've locked the wheels, I've moved the footrest out of the way, go ahead and stand up. Good. All right, let's turn and put your backside against the table and then let you have a seat. Okay, and now we'll just lay you down and get these pictures taken for you. Something like that, where they're doing what you're telling them to, but you are standing by ready to assist if they need it, but otherwise you're just literally telling them step by step what they're going to be doing. The assisted standing pivot transfer, you can see that these pictures tend to not go with the pictures are always beyond the words. So the assisted standing pivot picture is on 146, and they actually talk about it on 145. But you can see she's in the wheelchair. Let's assume he locks the wheels, and then she's going to scoot to the front of the wheelchair, and then he's using this transfer belt to help her stand up. He's assisting her and lifting her out of the chair, and then her center of gravity is close to his center of gravity. He's going to help her turn or pivot to put her backside to the table so that she can then sit or lie for the exam. So you're assisting them to stand and turn to get on the table. Okay. One of the nice things that we have now is we have vertically adjusting tables or high-low tables. So a lot of times you can bring the height of the table down to the level of the wheelchair. And sometimes that's a lot easier, a lot less for us to do as far as lifting and doing things with the patient, because when the height of the table goes down, it makes it easier on them to move. The two-person lift, literally, these two people are lifting her out of the wheelchair, and then they would likely put her, now granted, they don't have anything there, which is kind of weird, but ideally you would have the table right here, so they would lift her out of the wheelchair and then onto the table. Again, the person at the head directs the transfer. The person at the feet just follows their lead. And notice how they have crossed forearms. That is so when they're reaching under their axilla or under their armpit and grabbing the crossed forearms, it just helps so that when they're holding the patient's arms, they don't flail their arms out and you break your hold and drop them. Okay. Sometimes if they get panicky that you're going to drop them, their instinct is to throw their arms out to the side. But if their arms are in front of them like this and you're reaching and grasping their crossed forearms, then that's not going to be the case. All right. And that, again, the picture for that is on 147, and the words that they use to describe it is on 145. The last one is the hydraulic lift. As far as wheelchair transfers, the hydraulic lift, again, this literally is and looks exactly like, because it is utilized as an engine hoist, right? So there's spreader bar up here. There's a manual pump to raise and lower this bar. And when you use the hydraulic lift, you typically are using it when patients are too heavy to manually lift. You can also use this on patients that are paraplegic or quadriplegic, typically quadriplegic because they're not able to help at all. We always used to use these on quadriplegic patients. It uses the power of the hydraulic fluid to handle the extreme weight, and it's got an adjustable base of support, which is nice. Like this base right here, these wheels can spread out farther, or they can come narrower in order to adapt to where you're trying to push the ship. We use a lifting transfer sling when you use a hydraulic lift, and most lifts have standard features, meaning if you've used one, you can usually figure out any hydraulic lift or Hoyer lift. We typically have the patient, they're usually seated in a wheelchair. Sometimes they don't come in a wheelchair like this, especially if they're quadriplegic. They might come in those electric motorized wheelchairs, but most patients have the lift sling underneath them. It typically has chains on it, and those chains actually connect. There's chains on both sides. They connect to this spreader bar so that is what actually lifts the patient up. Okay, so they come with this lift sling or transfer sling underneath them. And then once they go to move it, again, the chains go on that spreader bar, and we raise the patient up. We swing them over to where we need them and then lower the bar down so that you're not doing the lifting. The lift is. Now, granted, that size patient, not really ideal. I don't know that she's too heavy for two people to lift, but maybe he's by himself and he can't pick her up all alone, so he chose to use that hydraulic lift. Notice it says when you send a patient back to the ward or to their room sitting on a sling, it's better than risking injury to the patient, the mover, or both by attempting to transfer without a sling. You cannot use these hydraulic lifts without a sling. And the key to all of these transfers is communication with the patient and with other workers. Now, what happens if they're not in a wheelchair? If they are on a cart or a stretcher is typically what I tend to automatically replace the word cart with stretcher. But people that are transported by a stretcher or a gurney have to move from that gurney or stretcher to the table as well. So there's different things that we can utilize to help move that patient. Again, anything that has wheels, make sure the wheels are locked and that they do not move. All right. Allow the patient to do as much of the move as they can. If they say that they can make it from the stretcher over to the table and they look like they can't, then let them do it. You just want to stand by and make sure that they're not going to fall in the process. Typically, when you're transferring a patient from a stretcher to the table, it requires 3 people. All right, 3, I would say, technologists, not, the patient's 90-year-old grandmother, yourself, and the security who's out in the hall. Typically 3 medical personnel to move the patient. You always want to use transfer aids if you're able to. And then for a lateral transfer, both of the surfaces have to be side to side, as close as possible, and at the same height. And a good example of that is on page 150. All of the images where they're moving the patient from the stretcher to the table, notice that they're at the same heights, which typically you can either raise or lower the table, or you could raise or lower the stretcher, either way, to make them even. When we do these cart to table transfers, typically we use a transfer device. Right here they have what's called a slide board. So notice that there are 3 people. One person is always in front of the patient so that when they roll her up, she does not feel like she's going to fall off the stretcher. Even though that side rail is up, that person is standing there pushing that stretcher against the table, or not even pushing. Like, the wheels are locked, but they're just putting their body weight against it so that it doesn't go anywhere. They're rolling the patient away from the table, putting that slide board underneath the patient and the sheet that the patient is on. Then they roll the patient back onto the board and make sure that they're actually on the device with that draw sheet. And then you pull that draw sheet along with the patient over onto the table. Okay? Doesn't require a ton of effort if you do things right and take the time to do it. So rolling them up, having someone stand and make sure that the stretcher doesn't slide out, using that slide board, and then using the sheet to slide them over. It just makes you work smarter, not harder, and then ideally none of those 4 people end up with injury. When they're using just a draw sheet, notice how they roll up the edges of the draw sheet. If they don't have the slide board, this works too, where you both, the person at the head and the person at the feet, grabs that. They're pulling, and this person in the middle, putting pressure against that stretcher, holding it close to the table, is pushing. Notice there's no gap between the 2, and that they're at the same height. So these 2 pulling and this one pushing can allow that patient to get over safely on the table. Just like with the wheelchair transfers, typically the person at the head is responsible for the transfer. They call out, okay, we're going to move her from the stretcher to the table on 3. Everybody good? 1, 2, and 3. And then they move her. Right? All right. This is something that is not in your book, but it is important. Skin damage that happens from transferring patients. All right, this can happen. It can be evident in as few as, it can be immediate up to 1 to 2 hours later. It occurs typically going from one surface type to a different surface type. So maybe you're going from the sheets on the stretcher over to the x-ray table, which is typically like the tabletop is usually slick, but a completely different surface than a sheet. It's caused by several mechanical factors, and it is very common with elderly patients because a lot of times your elderly patients have very thin skin. So you have to be very, very mindful when you're moving patients that you try and keep their arms crossed over their chest, try and limit how much skin is in contact with the surface area so that you don't injure the patient, because if that happens, it just brings about an incident report, which is fine. I mean, things happen, but you want to try and minimize that as much as you possibly can. On page 151, there are these images, but I want you to turn to that page because we're going to talk about a few things that go beyond this slide. So these are common recumbent patient positions. And the word recumbent, the first thing I would tell you that recumbent means lying down in any position. So the fact that they are all images of a patient lying down, these are all recumbent, okay? Lying down in any position. We have supine, the patient is lying on their spine. This is supine, or on their back. When they're prone, they're lying on their stomach. Typically, I would say face down, but most of the time your face is not down unless you're in a chiropractic table where there's a cutout for your face. Usually the patient's face is turned either to the right or to the left. Lateral means lying on your side, but typically to go beyond just lateral, this particular patient is lying on his right side, so this is actually a right lateral. These are all terms that we use, but when we speak of someone in a lateral position, we typically identify either a right lateral or a left lateral. So to be specific, you might want to write in your book that this patient is actually in a right lateral. This one is called Sims position, and the biggest issue I have is that this picture is actually incorrect. All right, this patient is lying on his right side, but Sims, the patient should be lying on their left side with their right knee bent, and this person is the opposite. They are on their right side with the left knee bent. So this image is wrong. It should be flipped the other way. So his back should be to us if he's like this, and his on his left side with his right knee bent. Now, why do we utilize Sims position? This is the position that the patient is in during a BE when we are about to insert the enema tip. They lie on their left side, bend their right knee forward so that the enema tip ends up going in a little more easily, and it allows the abdominal muscles to relax the sphincter so that the tip goes in. So again, make sure you note in your book that this picture is incorrect. He should be flipped and be on his left side with his right knee bent. This position right here is how we find most patients in a stretcher when we go to get them. This is called Fowler's position. And Fowler's position is where the head is above the feet. The heart is above the feet. So a semi-erect position, we would also call this. The patient is semi-erect, halfway up. This is Fowler's position. And the only other one that I would tell you that they do not have an image of is called Trendelenburg. Trendelenburg is Trendelenburg. When a patient is in Trendelenburg position, their heart and head are below their feet. So imagine you have someone lying on the x-ray table and they feel like they're about to pass out. The radiologist might tell you to lower the head of the table so that their feet are slightly up and their head is dropped down. That's one common reason why we would use Trendelenburg. They also use that when they're doing myelograms, where they look at the spine with contrast media. Sometimes they'll put the patient in a Trendelenburg position to allow the contrast media to run up the spine, but not all the way to the brain. So again, Trendelenburg would be the only other image I would add down here, where the patient's head would be down here, the table, and their feet would be up. Okay, so if you imagine this coming down further, their feet would remain here, but their head and torso would be lowered. Some patient positioning considerations that we have to be mindful of: talk to the patient, explain what you're trying to do, because most of the time they want to help you. Let the patient assist as much as possible. Check before you move the patient. Make sure that they're able to do it. Make sure that the chart doesn't say different, that they're not allowed. Always roll the patient towards you. You never want to roll a patient away from you. If they were to fall, there's nothing there to stop their fall. Whereas if you roll them towards you, they feel safer, they feel more secure, and they're not likely to roll off the stretcher or the table. You always want to provide positioning sponges to help the patient maintain their correct position. We'll talk about that a little bit more in the next chapter. And you always want to work as a transfer team, talk to the team members, working through before you actually execute. Why? Because when you communicate with the patient and the team, it's critical so that everybody remains safe and uninjured. There's always a clear leader on the transfer team, which is typically the person at the patient's head. If the patient can assist, absolutely let them assist. And you always want a wide base of support and maintain your center of gravity over that base when you're lifting something or someone. And always use positioning aids if possible. That brings us to the end of chapter 13. So if you have any questions or comments or concerns, please make sure you write those down and we will address them the next time we meet. Thank you so much.